Thank you once again, Professor Khanna and Professor Henry, for this kind invitation. I'm very honored to be here again. Hope next year we'll be there in India in person. Well, we're going to talk about our register from EVAR. We call it the Endolong. That's a cohort of almost 400 patients with midterm results. I have two disclosures. We received grants from Medtronic and from Gore, but of course we are very enthusiastic regarding this topic. This is a prospective cohort with almost 400 patients. Our aims are to register the mortality rates, its causes and risk factors, the endoleak rate, its types and risk factors, and the reintervention rate, and aortic morphology, pre and post-operative. So in 386 patients, we treated that were treated for AAAs or aortoiliac or isolated iliac aneurysm from June 2012 to January 2017 at two hospitals here in my home city, that is Belo Horizonte. 75%, 3/4 of the patients received the endurant graft, 21% the excluded graft, and 4% the endograft. The comorbidities and risk factor, the usual suspects, with hypertension in the vast majority of the patients, smoking, dyslipidemia, obesity, heart disease, alcohol, diabetes. Diabetes surprised me with 15%, cancer, previous AMI, and COPD, and so on. Regarding the measurements, the preoperative aortic morphology, we had a maximum diameter of 57.3 with the proximal neck diameter of almost 23 millimeters. The proximal neck length was of 30 millimeters, and the proximal neck angle with a mean of 37.7 degrees. We had almost 20% of the patients with the proximal angle higher, above 70 degrees, 60 degrees, and almost 10% with the proximal angle above 75%. We have 9% of the patients with more than 50% of circumferential thrombus, and 2.3 patients with more than 50% of circumferential calcification. Therefore, we had almost 1/4 of the patients outside the instructions for use of the endografts. So this is in-hospital data. The ICU length of stay was almost 2 days mean. The global loss of stay was 8 days, which for me was a surprise because this is very high, with a mortality, in-hospital mortality, up to 30 days of 2.6%. In the literature, the mortality is a little bit lower, with the EVAR-1 from Dr. Greenhalgh from the Imperial College of 2.3, in the Cochrane systematic review of 1.4, the over 0.5%, and the ENGAGE, that is the register of the Medtronic, on 1.3. So we had in real world a little bit higher than that. The cause of death were arterial rupture, sepsis, acute myocardial infarction, mesenteric ischemia, and one reperfusion syndrome. In the multivariate analysis, the risk factors for in-hospital mortality were age, the proximal neck diameter, and the calcification of the proximal neck. Pay attention in the proximal neck that these sorts of issues will appear very frequent regarding mortality. So the proximal neck is a prognostic marker. As age was one of the risk factors, 40% of the deaths were in octogenarians. Well, we had 3.3 reinterventions for endoleak, 2.1 for acute limb ischemia, with 6% of reintervention rate. In hospital, endoleak was not a risk factor for mortality. However, the in-hospital endoleak increased global mortality, which means at midterm, during the follow-up, the presence of in-hospital endoleak, and also increased the aneurysm-related mortality. The follow-up was around 18 months. We had 3.1% loss to follow-up, 1.6 quit, and we were able to follow 95.3% of the patients. During the follow-up, we had a mortality of 13.5%, which gives us a global mortality in hospital plus follow-up of almost 16%. And the majority was non-related to the aneurysm. We had indeterminate 20% and aneurysm-related around 8%. The global aneurysm-related mortality among all of them was 1.2%. Indeterminate in the 3.1, which gives us a total of 4.3 patients. In midterm, in the literature, the EVAR showed a mortality of 21%, the ACE 11%, the over 7%, and if I'm not wrong, one of the over was 7%. Okay, the risk factors for mortality during the follow-up was again age, gender. Women died more frequently than men, COPD, and the presence of in-hospital endoleak. And again, the proximal neck calcification was a risk factor for mortality, for global mortality during the follow-up. Calcification more than 50% increased in almost 20 times the mortality, and larger proximal neck also was a marker for mortality. Endoleak during the follow-up we had almost 10% of endoleak rate. Most of them were type 1. And risk factors for endoleak was proximal neck greater than 60 degrees, was a risk factor. Regarding the morphology, the post-operative morphology of the aneurysm, we had a global reduction of around 10% of the aortic diameter. However, in the population, the subpopulation that had endoleaks during the follow-up, the mean maximum aortic diameter increased over time. So almost 20% increase. So the proximal neck diameter during the follow-up increased from 23 to 24.5, almost 24.4. So with a mean increase of 1.6 millimeters during follow-up. This was very significant and again was a risk factor for mortality. So the proximal diameter is a marker, is a prognostic marker. The proximal neck angle above 60% was a risk factor for endoleak, and we had a reintervention rate of 7%, mostly for endoleaks, of course, some for limb ischemia, for pseudoaneurysm, with a global reintervention rate in hospital plus during the follow-up of 12.4%, and the majority of the patients, 87.6% were free from reintervention. The risk factors for reintervention, again, was proximal neck, above 60%. The increasing neck diameter, so we realized that the proximal neck was a marker, a prognostic marker. So in conclusion, register should be encouraged to know who we are and where we are regarding the EVAR treatment. Again, EVAR early mortality is very low, increasing over time, just as the trials. Although aneurysm-related mortality is low in short and mid-term. And aortic morphology is prognostic, particularly the proximal neck. And a reintervention rate is still a concern. Thank you once again for your attention, and I am at your disposal for comments and questions. Thank you.
Thank you very much indeed, Dr. Navarro, and congratulations on a very, very thorough examination of your patients. A little question really from my point of view would be, how important is it that patients are followed up with surveillance in the long term? Because
qu'est-ce que je fais?
Thank you, Dr. Reed.
Oui.
I think there is some noisy.
There is some interference maybe, but how important is surveillance? There was recently a paper in the United States where about half of the patients, and it was a huge number of patients who were undergoing EVAR in different studies, they weren't given, for one reason or another, they were lost to follow-up.
Yeah.
And yet these patients, when they were eventually found again, were found to do at least as well as those who got very regular, careful follow-up, and therefore perhaps more reintervention. What do you feel about that?
Yeah, thank you, Dr. Reed, for your question. This is not, although I say a real world, but we keep a very close eye on those patients. Now we have almost 500 patients being followed up, but we phone them, we call them, we go after the patients. So otherwise, it would happen like just you said. Many patients, most probably, will lost to follow up when they come back in a not satisfactory situation. Probably those who come back are the worst ones, with the migration, with leaks, and all those issues. But in our university setting, we are able to follow them. We have a very small portion of patients lost to follow-ups, and even smaller that quit. So we keep a close eye on them, and that's what we do. We follow
well, it's
them.
a very, very lovely thing to see how thorough your follow-up and indeed your preoperative data is. It's an example for many people, I think, to follow.
Yeah.
I think we are a little tight for time, so perhaps if Jacques is available, can we have that as the last presentation, I think?